The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our September 4 Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan, and just a few announcements before we get started today. Next week is our Virtual Leadership Institute event, and Dalton will be telling you a little bit more about that. And because of that, there'll be no Wednesday webinar on September 9. However, we will reconvene with Safe and Calm on Friday, September 11. In the interim, we ask that you look for our COVID updates. They're often sent out at the end of the day. Or look at our listservs a little bit more closely. We will be sending out updated news using that mechanism. We know that sometimes, at the last minute, a whole bunch of guidance will come out at the same time. So for today, we have our basic routine agenda. And Dave Herbal is joining us this morning to discuss the Nursing Home Preparedness Task Force and their final recommendations as sent to the governor. But before that, we will go to Dalton, our Director for Public Policy, who will provide a legislative update.
Good morning, everyone. Thank you for attending today's call. I know Fridays can be busy for a lot of people. Today's advocacy agenda, we're really focusing on three main areas. There are a lot of bills moving right now. As you may have known from following these calls, the Michigan legislature is back in for the month of September, trying to get a budget deal done, and they're looking to take all of October off, or a majority of October off, to then work on their campaigns for re-election. And so September has become incredibly busy, and they're trying to jam a lot of work in between the budget and all the other things that are going on. So we'll be talking about a couple of the bills that we've been tracking. And then we'll also be covering the MDHHS infection control grants, which if you attend the nursing facility check-in call, I believe, that MDHHS hosts on Thursdays typically, they have been talking about on there, and I'll go into some detail here. And then we'll be reviewing the PPE grant update, or grant updates, and running over the FAQ for everyone, as we've been receiving some questions about the process for this application. As Deanna said, our Leadership Institute is, our Virtual Leadership Institute, I should say, is next week, which is kind of crazy to think about. Came up on us really fast, and we're really excited to have a lot of leaders in the field presenting there. We have a great breadth of topics, from kind of big picture budget items to reimbursement issues. We have a wide variety of topics available for this institute, and we're excited to have Dr. Robert Gordon, Larry Horvath, and Dr. Alexis Travis joining us, as well as a lot of other key speakers. All right, so as I said, the legislature is in. And so we're going to be using this section to run over, I think I put in here, 6 bill packages, quote unquote, because one of them is actually one bill package, but consists of 10 bills that I think would be of interest to everyone. So the first one is Senate Bill 111, which is a healthcare licensure bill. It would make it so that anyone who reports a person with a healthcare license for a controlled substance issue or a pharmaceutical grade cannabis issue would have to then send an affidavit in with their allegation to the department, and the department would have to keep that on file and provide that to the appropriate people moving forward. It currently reads that this affidavit would have to be signed under penalty of perjury. There is a substitution that was introduced in committee to remove that penalty of perjury. The bill's still in committee, so it's still being worked on, still very early in the process, but just something to keep our eye on and something we've been watching closely. Next, you may hear that there's a lot of stuff going on with the budget. This bill in particular, 6117, House Bill 6117, shifts funds out of the CON commission and back to the general fund. They're trying to get everything spick and span for fiscal year 2020, while at the same time having conversations for FY 2021. We've heard that these negotiations are going okay, but political insiders think that the FY 2021 budget negotiations will push more towards the October 1 deadline than I think a lot of people would like. But right now we've heard kind of good-ish news, if you consider okay good. Just an interesting one here. Senate Bill 1082 would move election dates in Michigan. It would eliminate the May and August elections and then move those elections to March and June. I think they just want to have more time between the elections and the end of the year or the next election cycle. So they're moving those back a month or two. So the next bill here is a healthcare immunity bill, which we're glad to see come back. This one is has the bill number 6159, House Bill 6159. But this time they're taking a little bit of a different strategy. They're not going to pass it separately. This is included in a larger immunity bill package that includes immunity for people like firefighters, police, the government itself. And this bill package will be in committee next week. The bill, as it stands now, is currently a duplicate of the old immunity bill that was vetoed by the governor. So we're hoping something goes forward here. And I personally like the change in strategy because it puts more on the line for the governor to have to say no to. Lastly, you may have heard, as I saw it in some Detroit news outlets, that a 10-bill nursing home package has been introduced. It's called nursing home, but really it affects a lot of different provider types. And it's kind of a bunch of different bills that are very different from one another, kind of jammed together here. This is sponsored by Rep. Love, who's a Democrat out of Detroit. The package is likely not to pass because of Rep. Love being a Democrat and the legislature being controlled by Republicans, but who knows, something may get done. Just a couple of highlights from the bill package, because it is 10 bills. One of the bills would create a SNF and HFA database for consumers that the state would have to run. Another bill would require HFAs to have at least 2 mobile devices for video calls. A third would make it so AFCs and housing will have to post where people can make complaints in a public area or space. Another one would require HFAs to notify families or guardians if a resident is relocated within 12 hours. Then another bill would make it so HFAs will have to notify all residents if there's a staff or resident member who has been confirmed positive with a communicable disease within 12 hours. So you can kind of see where people are coming from here with these bills, just trying to clean up, I think, what they view as some loose ends from what happened during the first wave of COVID. So we're moving on now to the Nursing Facility Infection Prevention and Control Enhancement Grants. These grants are designed to provide equipment to achieve more effective infection prevention and control in nursing facilities. These grants can pay for a portion or all of the costs for infection control equipment, and only Medicaid certified nursing facilities are eligible for these grants. So what this slide here kind of shows us what the process is and how much you can get awarded through these grants. NDHHS has established 2 award amounts. The nursing facilities in high poverty areas can apply for up to $22,000, while nursing facilities not in high poverty areas can apply for up to $18,500. This has been built into this grant application process to help address health disparities. As you know, that's been on kind of the minds of a lot of people nowadays, especially politicians. So this is kind of where we see it in practice. For ease of use purposes, a high poverty area is defined as an area of the state where at least 20% of the population is living below the poverty level. And the application itself, which I have attached to this webinar in the handout section, actually lists all the facilities that are considered in high poverty areas. So if you are interested in these grants, after we review them, or you already are interested in them, you can find out if your facility is in a high poverty area very quickly in the Appendix A attached to the application attached to the webinar. So the process for these grants, applications are due by October 31st at 5 p.m. Then the applications will be reviewed by MDHHS and LARA. Then providers will be notified of the approval within 10 business days. If you're approved, payment will be made through a gross adjustment within 2 weeks of that approval. And then documentation of your expenditures must be submitted to the department by February 1st, 2021, and the funds have to be spent by December 31st. This is all CARES Act money, so all of that needs to be spent by the end of the fiscal year, or end of the calendar year, excuse me. So I think the next slide will be discussing what they'll be reviewing. And so here are the criteria for the application. The department really wants people to apply for these because it's kind of a, you don't use it, you lose it scenario. So if you think you can apply for this, and later on we'll have examples of what kind of purchases are acceptable. But the review criteria for the application, firstly, the application must be complete. And the department will notify you if you do send them an incomplete notification. The equipment must be designed to improve infection control in a healthcare setting. Equipment must be appropriate to meet the stated need in the setting where it will be used, and the purchase and installation, if it's funded by the grant, of course, must be feasible by the 31st, because all the monies have to be spent by the 31st. So here's the examples, or just some examples. The department isn't limiting us or limiting providers to just these purchases. You can apply for anything that you think will help infection control in your building. You can see the examples there. I won't read them because I feel like that would just be a waste of time on everyone's part, but you can see some examples there. Important to note, though, that the grant funds may not be used to replenish infection control supplies used in normal operations, including but not limited to PPE and cleaning supplies. So the example they like to use is that these grants can be used to purchase the hand sanitizer dispensers, but not the hand sanitizer itself. So that's kind of where they're coming from on this. So now that we covered those grants, we're going to move to the PPE grant program, which we've been discussing for a while now. As you know, it's a $25 million grant to reimburse providers for PPE costs. And you have heard us discuss this on this call underneath Senate Bill 690 before, and then after that as Public Act 123. And it has been determined by the department from the legislature. The legislature told the department to make a process. The department made a process. And so the award amount for each facility is set by a formula that it is using patients that's client-facing FTEs as the base. There's two groups for this. Group 1 facilities will receive $1,000 per frontline FTE. And Group 2 facilities will receive $2,500 per frontline FTE. And the total award amount is capped at $250,000 per firm, which is defined as a EIN number. So if your organization shares the same EIN number, that's what a firm is. The application is due by September 8th, so we got 4 more days here. So who is eligible for these grants? You can see the list here. It's important to note, though, that nursing facilities, AFCs, HFAs, and assisted living and independent living providers are all included. Even housing providers are included in this. And then you can see the rest of the list. I won't go through and read them. This has caused some confusion, though, because the way they have listed the groups out, they have put long-term care facilities without referencing who is eligible for or who is defined as a long-term care facility in group 2. So a lot of independent living providers have been asking the question, aren't we a long-term care facility? Shouldn't we be in group 2? Unfortunately, that is not the case. Independent living is actually defined as a residential congregate facility underneath this definition that is included in this grant process. So independent living and housing is in group 1, while SNFs, AFC, home for the aged, and assisted living is in group 2. And then you can see all the other people and other providers in group 1 and group 2. So what are eligible for these, or what purchases are eligible? Surgical masks, filtering face piece respirators, gloves, gowns, eye protection. The supplies do not need to be FDA approved, but homemade supplies are ineligible for reimbursement. And the PPE must have been purchased on or after March 1st and delivered before December 30th, 2020. These are once again funded by CARES Act funds, so you can see that December 30th, December 31st cutoff date because the funds have to be spent by then. And you will need to maintain proof of purchase and delivery for these purchases made with the grant monies. I've attached the FAQ in the application as well as an additional FAQ that we just received this morning from Director Massey to the webinar. You can find them there. I've also posted the links to the FAQ and application on this slide for everyone. All right, now I have the distinct pleasure of introducing David Herbal, the President and CEO of Leading Age Michigan, to cover the task force, the nursing home task force that just took place, that was instituted by the governor.
Good morning. Thank you, Dalton, for that introduction and the good work on all of the information that you've been submitting. Certainly the legislature is very busy as they try to continue to promote their campaigns. But I was especially thrilled to see that the MDHHS is putting out the applications for the CARES Act funds. Certainly, I would encourage all of our members to take advantage of that where they can, as the department is looking to spend those dollars before the end of the calendar year. So get creative and where possible, get the funds that can help support your organizations. So thank you for your hard work on that, Dalton. And I'll start talking about the task force here in a little bit. So Executive Order 135 of 2020 empowered the governor's office, empowered MDHHS to put together a task force to take a look at the potential reaction of the state or state government in case of a second COVID wave hitting the state of Michigan. And it was a very interesting process. I know that we've had a lot of members involved in the program, and I think it's been a very enlightening program for anyone who's participated in these work groups. And the task force recommendations did go forward on the 31st of August. But what was really interesting in this was the goals of the task force. And it was to produce recommendations for the governor to ensure adequate testing, limit the spread of the residents, and secure PPE, and to build bed capacity for residents that do not require acute care. What was of particular interest in the work group in my work group and on the larger task force was the fact that we weren't really looking back to try to improve or evaluate the processes that have occurred in the first wave, but the potential to deliver some quick and more nimble responses should there be a second wave that occurs this fall and primarily in the middle of flu season. So if you can go to the next slide, that would be fantastic. Thank you. This is a slide that delineates all of the folks that participated in the COVID task force. There were a couple others from the department and a few legislators involved beyond the names you'll see listed here. But of particular interest is that, Leading Age Michigan had 3 representatives on the larger task force itself. So we've got, a caregiver, Maya Moore from Martha T. Berry, and Steve Kastner from Trinity Health Senior Communities, and myself. And so I feel we were very well represented, not only on this task force, but on the work groups. We had 12 other Leading Age Michigan members weighing in on the task force work groups themselves. And I think as we go through the recommendations in the coming slides, you're going to see that the not-for-profit presence in the recommendations that are moving forward to the governor. And I think that that's really something we can all be very proud of. So if you could advance to the next slide. So there are 4 groups, 4 work groups that came together to form a total of 28 recommendations that move forward to the governor. The reason why this task force is so important is that, at least in the published material most recently, 31% of the deaths in Michigan have occurred in our nursing homes. And there has been a very political process going on right now around everything related to COVID. And we'll talk about that a little bit more as we move through the slides here. But I wanted you to take a look at the recommendation that came from the first work group around resource availability. You'll see that this group wanted a more coordinated PPE distribution and allocation, improve the coordination and the prioritization of testing supplies, decrease the reporting burden on nursing homes by considering the frequency and the use of current reported data, designate certain labs specifically for the nursing homes. And most recently, we've seen some conversations going back and forth on the SNF listserv that kind of points out the importance of this as, the different labs all have different turnaround times. So this is a special recommendation that I think we should be hopeful for. And then third, a secured funding for continued testing and grant dollars, because reimbursement for the special specimen collection and point of care testing is going to continue to be a concern as the requirement is out there in the regulation, but the grant dollars may not be there in the future. So we want to make sure whatever recommendations go forward to the governor, that we're also trying to tie in the funding that's needed to make sure these recommendations, when implemented, are smooth. The next work group that came together was staffing. This work group, I thought, had really one of the key points that is essential to anything going forward. And this was, I think, their focus really kind of targeted in on the fact that not only do we have to address the issues that face the staff that we have right now, but we also are facing a staffing crisis, and we need to find alternative ways to try to draw people to the profession. So there was a recommendation to create a website that can connect candidates with potential candidates with employers. Also consideration to conduct public service announcements that will begin to show long-term care as a potential career with career ladders, provide adequate access to training and the pandemic, and to improve support of physical and mental health for our staff who are, certainly bearing the brunt of all of the issues that we're having day to day. Certainly the mental health challenges must be a lot, and a tremendous sense of loss with the residents who are passing or who are experiencing isolation. And establish a formal CNA career ladder. I think nothing points out the importance of a staffing recommendation to the governor, like the news articles that were recently published regarding the potential strike by the unions in Detroit. If you recall, I think it was mid-August, where 1,600 employees were going to strike a number of nursing homes in the city of Detroit. The governor at the last moment stepped in and got everyone to agree to a 30-day cooling off period so they could come back and revisit the issues. But we'll be in mid-September here. The 30 days will have run their course, and this issue is not going away. So it's going to be very interesting to see how this plays out and as we go forward, especially as everyone's concerned about a potential of a second wave. The next work group I wanted to talk about was quality of life. This work group, we lobbied heavy to get this topic into the work group, and kudos to MDHHS to allow the transition away from the 4 topics that they wanted to address and include quality of life as one of them. And so we just are very thrilled to have had an influence on this. This was the most prolific work group that put forward recommendations. As you can see, each one of them is so significant to what we're doing. And it talks about visitation, it talks about communal dining, it talks about on-campus, off-campus, window visits, and even clarifying some of the other orders that have been issued. So we're hopeful that these recommendations will point out to the department that not only do we need clarity, but we need to understand that our residents need to have a voice in what's happening in their lives. And it can't just be the epidemiologists who are establishing policy. So we're very hopeful that the governor will take a serious look at this and maybe find somewhere where we can meet in the middle and do things safely so that the isolation and the visitation can be addressed. So, and finally, the recommendations from the placement of resident task force. This really was a very challenging work group to be a part of. I'll tell you, I think we did some great work with this. This certainly is probably the most political work group and information coming out of the task force. Rep Love was on this work group, and I think that her bill package, her 10 bill package that Dalton was talking about earlier, also reflects back to some of the information that was embedded in our work group and the processes themselves. She has had a work group going in the House of Representatives looking at what happened in the city of Detroit during the first wave. And so I think some of her initiatives align with either the goals that came out of this work group or things that her constituency would like to see implemented. Of the most important in the recommendations moving forward here is to identify and coordinate with hospitals who have excess capacity if there's a second wave. The information that we've reviewed in talking with the Hospital Association and others is that there really was not, during the first wave, the hospitals really were not overwhelmed from COVID residents. I think they would describe it as being more overwhelmed in terms of, access to PPE, staffing issues, and then, some of the reimbursement challenges. So, this work group encouraged the department to work in conjunction with the hospitals to see if there was a way to keep the residents at the hospitals a little bit longer and relieve some of the burden on the skilled nursing facilities before having COVID-infected residents returning back to the nursing facilities. Additionally, the task force took a look at the regional hubs and decided to rename them in the go forward to care and recovery centers. We've updated the guidance and the protocols for the regional hubs. I think this is where the topic gets very political. There's an organization out of Ann Arbor called the Center for Health and Research Transformation Chart. They've also published a recommendation that I have not seen yet. I haven't seen it published anywhere, but their conclusions were that the regional hub program in the first wave was largely successful, and that with some tweaking of that process and maybe selection criteria that the program could move forward more efficiently. If you go to their website, you'll see a link with Michigan Public Radio, where they're addressing some of the outcomes that they found. And the director, Marion Udall, actually recommends that the Michigan process around quality really needs to be more focused on training tools and a learning environment, and to become less punitive in terms of, I think, survey citations and that sort of thing. So a lot of information happening in these committees, and the regional hubs will, of course, go forward during the process. The last recommendation moving forward here is for admission of COVID-19 residents into facilities that are not care and recovery centers. This will only be under exceptional circumstances. So in other words, if the hospitals can't handle the overflow, and then the care and recovery centers cannot handle the volume, then we'll be looking at nursing facilities that are not part of either one of those earlier processes. And the fourth recommendation was to continue to explore the creation of dedicated facilities and alternative care sites. I will tell you that the language in here, in this kind of hierarchy, is rather permissive in terms of, the first goal with the hospitals is, hopefully that MDHHS can work out some sort of agreement with them, and then the regional hubs and on down. I'll tell you my personal concern with all of this is that we will, absent those kinds of agreements, we'll basically have the same system that existed in the first wave. And hopefully that won't be the case, and that there is some additional criteria built in here. But that has been a concern all the way through the process for me and for others. I will also share with you that in terms of the political aspects of all of this, as you all know, recently there was a news release where the governor's press secretary commented on some of the executive orders that really, I think, did not provide an accurate reflection of the intention of those executive orders. Yesterday afternoon, we were fortunate enough to have Deanna speak with Guy Gordon on the afternoon WJR radio. She did a very good job representing our interests, but these recommendations were the ones that Guy Gordon, honed in on and went directly to. And I think that also kind of leads to some of the politics of this. And then I just want to mention one more thing before I turn the webinar back over, and that is, in the last weeks, we've seen, our Attorney General take a pretty strong stance on senior living facilities, issuing cease and desist orders around $900 fees for PPE that have been implemented on some family invoices, as well as at a national level. Attorney General Barr indicate he wanted to investigate 4 states that had seemed to have had a number of deaths in their nursing homes. And just to say that this environment and how COVID is being politicized is going to be very complicated. I feel that, our governor and some of the very conservative restrictions she's implementing on our profession may largely be due to the political tension she's feeling and the exposure that she has. And so, we as an organization need to be very careful in our messaging. And our board of directors is very sensitive to that topic. And we've actually formed an internal communications task force where we're going to be interviewing communications and messaging experts to start engaging in some of these discussions, not only for ourselves, but with our family members and our residents. We believe that it's really an important time to give the voiceless a voice. And I'm really looking forward to that. We've got an RFP out there right now and expect those responses back very soon. And we'll hopefully have more information for you by the business meeting coming up during the Leadership Institute on the 9th of September. So a lot of information inside of that. I apologize for carrying on, but I wanted to share all that information with all of you. Thank you for your time this morning, and I'll turn it back to you, Dalton or Blake.
All right, thank you for that, both Dave and Dalton. Before we can get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our annual conference and the Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Let me go ahead and pull the questions up really quick and see if we have any. If not, we can go ahead and move on. All right, it actually looks like I do not have any questions right now. So Deanna, if you'd like to move on, we can keep going, and I'm sure the questions will come.
Sure. So moving ahead, we're going to do a very brief situation update this morning. I do have more slides in here that I'm going to speak to. A lot of them are self-evident, so we'll move forward, and I might comment just briefly on each one. So move forward, Blake. This is the WHO map for the world, obviously. We have seen some improvements in the U.S. Comparison to other areas. It looks like South America is the only one who has really, really high transmission rates right now. But note that the U.S. continues to be a fairly high transmission rate as well. This is the slide that talks about the hotspots. You'll see that it covers most of the U.S., and fortunately, Michigan is not there. So that's a good sign for us. Moving on. I'm not going to go through this data. It is for your information. The CMS issued its monthly findings for Medicare beneficiaries. It talks about the increasing caseload. The only thing that I would want to note is that 29% of beneficiaries who go in the hospital are able to go home directly, and 24% unfortunately have passed on. The rest we assume are going to post-acute care or some other setting. This is an interesting slide, and this slide is specific to Michigan. So this is Michigan data, and it has caseload on an ongoing basis throughout the pandemic. And the colored dots and lines have to do with the governor's movement in terms of restrictions and closing. So you can see that there was early restrictions, quite a few when the pandemic hit. The caseload went down. The blue-green dots really are representing reopening of certain aspects of the businesses and public events. And then you'll see that caseload starts going up and the governor clamped things down. So it's kind of an interesting slide for Michigan. Our caseload overall and our trends are different than other states, but overall we are looking pretty stable. This is our caseload in comparison to other Region 5 states. We are the blue line in the middle. We're doing a little bit better than we were a couple weeks ago. This is our caseload slide. You'll notice that it's improving, and after peaking a bit, so we seem to be doing better in terms of overall Michigan caseload this week. And daily COVID deaths seems to be stabilizing, although it is important to note that unfortunately our death rate is higher than a lot of other states. I think we're number 9 or something like that last time we checked. So this graphic I put in here only because we're going to talk about assisted living a little bit more today than we often do. These are the states that report caseload among residents and staff in assisted living facilities. It's put forward by the Kaiser Family Foundation. The painful thing here is there's only like 19 states or something like that reporting, and you'll note that Michigan is not one of them. And the problem with Michigan is that because assisted living is not defined in regulation, the state still doesn't know where all the assisted living facilities even are. So our reluctance to report has to do with the fact that we don't have good data at all. And this is the end of our section on the situation. This is our Safe Start map, and unfortunately it still has not changed since last week. It includes data through August 30th. So we're going to move on to our announcements, updates, and guidance. We have seen a lot of movement in the past week in several programs, lots of little details to go over. We'll try to do that kind of quickly today. What we're going to start with is a review of the CARES Act provider relief grants, because there's been a lot of movement in a lot of these programs in the last few days even. Note that phase 1 distributions were sent out without any application requirements to providers, and they were based on a formula that includes the amount of Medicare revenues each healthcare provider receives. And then with phase 2, the feds changed all that and decided to provide a total of 2% of all patient care revenues to healthcare providers, and there were some eligibility rules around that. So if by phase 2, if a provider had not received 2% of patient care revenues during phase 1, they could also apply for additional funds in phase 2. And then there were some targeted distributions in addition to that. Nursing facilities got a fixed amount in their targeted distribution, plus an additional amount based on the number of beds. So the first tranche was $50,000 per facility and $2,500 per bed beyond that. And then there was a second set of funds distributed, and these were distributed to facilities starting last week. So if you haven't looked at your bank account, you should probably check it. Per facility payment of $10,000 and a per bed payment amount of $1,450. The terms and conditions for all of these provider relief funds are the same, but I have included the link to that guidance that came out from HHS. There are no mandatory training requirements so far with these funds. CMS seems to have backed off from that idea. However, the funds have to be used for PPE, staffing, or testing, definitely for infection control expenses. And most importantly, in the last week, on September 1, HHS announced a general distribution for assisted living providers, and you must apply very soon. The due date is very quick. And again, that would include 2% of patient revenues. On September 2nd, HUD announced some grant relief funds for service coordinator programs. And on September 3, HHS announced the details of the additional $2 billion performance-based incentive payment that's going to go to nursing homes. So for the assisted living funds, and this is an important piece, there is not a lot of officially published material about this yet. But Leading Age this week has been in ongoing conversations with HHS, and they've told us that assisted living providers have to be state licensed or certified to receive these funds. Now, we're going to try and clarify that. And in most states, that probably won't matter because in most states, assisted living is licensed and or certified. But in Michigan, we know that we have a huge unlicensed component, and so that is a problem potentially here. The same portal and terms and conditions apply for these grants as for our other grants, and the link for all of that is right there. That's the landing page, and it pretty much links to everything else that you need. Assisted living providers should note that they have to apply by September 13th, and that this date probably will not be extended. A lot of the other dates have been, but I wouldn't anticipate this. Members need to only complete the first step of the process by September 13th, and it's pretty easy. And that is, you need to enter your tax identification number for validation purposes in the portal. And once that's validated by HHS, you'll then receive an email with the next steps identified. Some assisted living providers submitted data in July and August through a Leading Age collaboration with other organizations through this portal that they built together. And if you submitted information through there and you want to apply for these funds, you still have to apply through the HHS portal and have your TIN validated through that process. Again, this is for 2% of total patient care revenues. Leading Age wants to make sure that private pay nursing homes are included in this process. And they also identified that if your TIN is not validated right away, please contact Nicole Fallon at Leading Age, since they've been advocating and working with facilities to make sure that these funds get to where they want to go. Service coordinator grants. They are going to be awarded through Grant Solutions. If you have a program that's covered under the service coordinators in multifamily housing or the congregate housing services program, you would be eligible. You must experience or expect to experience increased service coordinator expenditures between March and the end of December. And Leading Age is going to be holding a conference call next Wednesday with HUD staff to review the details about this. And there's a link to further instructions here as well. In mid-August, HHS updated its FAQ on reporting requirements and auditing. So anyone receiving over about $10,000 should expect to be audited. And the timing of the required electronic reporting is listed here, and it's not new. It's been out for a couple weeks. Again, the terms and conditions page and portal is pretty much the same for all these different grant options, but reporting of expenditures and what might qualify seems to again be up in the air. There is no official document for that. It's supposed to come out around October 1. And Leading Age has been a discussion with HHS over time about all of this. So they're now concerned that HHS seems to be changing its direction in terms of what is allowable under expenses. And so we're going to have to look for that final guidance as soon as it's reported. And Leading Age is trying to get some clarity about this with HHS as we speak. So this current iteration of nursing home targeted funding, about half the funds were sent last week, and the remaining funds will be based on performance. They're going to use the county community transmission rates and then compare a facility's caseload and death rate to that and determine a particular performance amount. So facilities do not have to apply for these funds. We're not sure how the grading is going to be related to the actual amount that's going to be provided, but they will be looking at individual performance by month, every month, from October through December, and they will distribute those funds automatically during the following month. So we're going to end this topic with a brief discussion about leading age conversations with HHS about these provider grants. Leading Age seems to think that HHS is redefining the definition of lost revenue, but they're hoping it is just based on inconsistent communications with HH staff. They also want to remind providers how to consider these grant and PPP loan revenues on their cost reports. Apparently, you do not have to offset the PPP or grant funds against expenses unless those amounts are attributable to specific claims. So this is not an area of expertise for me, and we would suggest that providers with questions might want to attend the Plant Moran seminar during the Leadership Institute next week. So we're going to stop for questions.
All right. Thank you, Deanna. Let me pull those up really quick. Looks like I just have one right now. For the most recent CARES Act funds, $10K plus $1,450 per bed, one of the options for spending the money is hiring staff to provide patient care or administrative support. That is very broad. And any interpretive guidance you can offer, will any wages paid to new hires this year to provide patient care qualify?
I don't have any more detail about that than what we presented so far, but we will look into that and see if we can find any more information.
Okay. As of right now, that was the only question that we had. So if you wanted to keep moving forward, we can.
Okay. So this slide is just a reminder from MDHHS about the fact that the Medicaid, some of the grants, the provider relief grants are for Medicaid providers who are not Medicare providers. And so they're just notifying everyone that there is an extension for those provider relief grants to September 13th. And if you want to review their reminder about that, there's the link. So now we'll move to a brief review of executive orders. These are the executive orders released since last we met. We do know that the governor last Friday extended the visitation restrictions with no changes. But, you know, they did state in the executive order that MDHHS continues to have the ability to modify these restrictions. And this is not new. And also that the governor will be considering the task force recommendations submitted last Monday. And then, of course, I think it was yesterday evening that she extended the state of emergency again to October 1. Last week, the CDC made a surprise move and halted all residential evictions. This is very unusual. It usually doesn't come from the CDC. But they did this by making evictions a public health hazard during the pandemic. So this extension to restrict and prohibit evictions will be effective through December 2020. But the rule is still unpublished. It's expected to be issued today. The link to the unpublished rule is listed here. And persons who will be covered under this exemption must complete a declaration statement. And the link for that is also included here. And the only other CDC update that we could find in the past week is about how healthcare settings can make a chlorine solution to disinfect. So we thought that was interesting. It might be helpful to some providers, so we threw that in there as well. Antigen testing. There is some movement here. Yesterday afternoon, MDHHS put out a notice on the MyHand system from Dr. Calhoun that discussed the use of antigen testing in Michigan. And to be honest, that notice really disappointed us because for the most part, it only replicated what CMS, CDC, and the FDA have stated so far. But it did state that antigen tests can be used for diagnostic and screening testing purposes, and it also identified the reporting requirements. So positive cases, and this is a question that we have out to the state already, only positive cases are noted here in the guidance, must be reported to public health within 4 hours of receiving the result. Reporting must include all the demographics listed here. However, there's no information about reporting negative tests. And we can't imagine how the fact that without a laboratory involvement, that the state isn't going to want to know how many tested negative. In other words, if you're only reporting positive, you know, is it 2 out of 100 or is it 2 out of 4 tests? So I can't imagine that they're not going to have some requirements about that. So we have a question out to the state concerning that. The thing that was disappointed is that there was nothing in this guidance about how antigen testing falls within the other support that MDHHS is providing for testing. So last evening we contacted Erin Emerson at the state, who coordinates the testing guidance, and she stated that all the same reimbursement rules apply to antigen testing as for other testing. So we assume that they will pay for test kits and they will pay for staff collection time, but we would like to have that in writing if possible, and we're looking for that, and we'll let you know when that comes out. But she assured me that indeed the state will continue to support payment for and reimbursement for antigen tests as well as the others. This week, HHS also announced that they will be sending the Abbott point of care test to assisted living entities as well as other entities such as schools. These tests, if used properly, are considered much more accurate, and they do not require a machine at all. So the specimen is simply placed on a card, and if that card changes color based on that, whether or not the test is positive. Let me restate that, that was messy. The specimen is placed on a card, and the card has markings on it, kind of like a pregnancy test, and if those markings change color, you can tell whether or not the test is positive. We don't have really any more details about how this is going to happen at this point, or who can actually, under the assisted living title, be eligible for that. Another thing from HHS about antigen testing, apparently there was a lot of problems with a couple states. They got pushback from, I think, 2 or 3 states who were reluctant to consider antigen testing for screening purposes, especially in nursing homes. So what HHS did is that they used the PrEP Act to provide immunity to any physician or healthcare provider who orders or conducts the test. So through that, they're getting around the state saying you can't stop these clinical people from using point of care tests. One of the things that we noted this week is an article by Atul Gawande. He is kind of a leading healthcare expert. And one of his issues is that, and this has impacted nursing homes and other long-term care facilities in Michigan and elsewhere, is that there just isn't the system out there to distribute and ensure that everyone has the supplies and support that they need through these pandemics. He believes that there has to be a coordination system that links employers, schools, nursing homes, institutions that need testing to those who have the capacity to deliver it. And he's worked to form an interstate compact where he is to buy and distribute the rapid testing devices and supplies. So this is the kind of issue that we offered to the governor during the task force, that we need some specific coordination from the state, working with these suppliers, making sure that these products get to the places they need to go. Another update is that CMS has finally completed its project to integrate all of the healthcare compare sites, nursing home compare, hospital compare, et cetera, into one. We've not really looked at it yet. It'll be interesting to see how that worked out. Other recommendations have come out for the equitable distribution of COVID vaccines. And the recommendations are that priorities for persons in nursing home, assisted living, home-based care are going to be very high. And that also includes older adults living in congregate or overcrowded settings. So that's important to know as we get closer to the possible use of vaccines. And HHS will be shipping 1.5 million N95 masks to nursing homes who need them. And that's based on those who indicated a need through NHSN reporting. These shipments supposedly already started. I don't know if any members have received them. So we look forward to perhaps having a decent supply of those. We were also notified this week that MDHHS will not be reporting caseload data on Sundays, although providers still need to report daily. We have asked the department through the task force to look at this requirement, especially because of the burden of reporting on weekends, but at this point, that has not changed. So as we get to the end of our presentation today, we wanted to list the outstanding questions that we're working on for some of our members. And if you have issues or questions that are not listed here, do please send us a note through the Safe and Calm email address, because what you're asking us are the things that help us identify the content of our presentations, and also they define our conversations with the state as we try to get answers for that. So one of our members identified, and I at least had missed this before, that the unlicensed assisted living was not included in Executive Order 172. And that is the order that exempts healthcare employees from working if in contact with a COVID positive person, assuming that that would have been with full PPE, et cetera. So healthcare people who come into contact with COVID positive people who have protection on are exempted from having to stay home, but not for unlicensed assisted living. So we've not really heard a response. I must have asked that question 2 weeks ago, and I'm still waiting for that. Another issue that has come up in the past week or so is that one of our members told us that hairstylists were okay to have in their facility. Hair care was okay to do in their area based on their responses from the surveyors. Well, that was not our understanding from almost every other region, and we have heard from surveyors that that specifically was not required. So we did reach out to the state about that question, and they did get back to us just before the webinar today and said that they did not say that hairstylists were okay. And they were thankful that we brought the discrepancy up. But they also noted that the governor is going to be revisiting this with the task force recommendations. And so they're looking perhaps maybe a little bit more positive that they might be changing those rules. Another thing that we asked the state that they got back to us about today is that how to think about a contractor in terms of staff test reporting. If a contractor who's coming into your facility on a routine basis tests positive, are you supposed to report that person as your staff? The most recent guidance from the department is that if a staff person is works in several facilities and tests positive, you are supposed to report that as well as every other facility. So it used to be that you had to coordinate and make sure that it was reported once, but now they want it reported everywhere. Every facility that that person touches, if that person's positive, they want to know about it because that person's been in your facility. The question was whether or not a contractor had to do this. And one of our members came back and said that they were told, no, the contractors don't have to do this. Well, the state came back this morning and said, nope, contractors need to be considered in the same vein. So if you have a contractor, let's say a lab person, for lack of any other ideas, a lab person is going to your facility and going to the facility down the street, and that person's coming into your facility and tests positive, you have to report that as if it were a staff person. Another issue has to do with QSO 2028, where that guidance says that people who move in and out of the facility for appointments, dialysis, etc., have to be placed in a single room or an observation area. And we all know that we're talking to the state about this on an ongoing basis, and we're waiting for some clarity around that because we think that that's far too restrictive. But we want to know what an observation area is. So we're waiting for CMS to define that for us, because is an observation a bank of private rooms, or is it possible to have semi-private rooms in an observation area if everybody is kind of the same designation? We know that you can put COVID positive people together if you have to. If we have to put unknown people together, if we lack private rooms, can we do that? Especially considering the fact that we think the whole thing's too restrictive anyway. And so, again, we're looking at how negative antigen tests will be noted or recorded. So, moving on. Just a reminder that we did create a COVID quick facts document. The link for that is down here. We would like some feedback and any questions about it. We did note that the testing was very confusing. We tried to really narrow the information down and make it a little bit more clear. So please let us know if this works for you. We'll try and do it more often for these confusing kinds of topics if you find it of value. So before we go to questions, final questions for the day, I wanted to let you know that we had intended to go through the nursing home infection control focus survey piece today. We thought it would be a good idea to do that because even for non-nursing homes, it is a good summary of the kinds of things that everybody's supposed to be doing, and there have been updates and changes to that. But there was so much other content that was a little bit more timely for today. We're going to try and do that on September 11th, next Friday. And if you have any other questions or topics that you want to talk about, please shoot us an email through the Safe and Calm address. Okay, back to Blake.
All right, thank you very much, Deanna. I will pull the questions out really quick. Looks like we have a few, so I will just get into those. Just to clarify, the point of care testing kits we received are still to only be used for symptomatic testing or for symptomatic residents?
No, you can use them for screening. My only concern about that was that you're going to go through your test supplies very quickly if you start using them for screening. But it's clear from the MDHHS guidance that just came out last night through my hand that they are approving those tests for screening as well. So if you are using point of care tests and you can get your responses in 48 hours, by all means, continue to use them. They're more accurate. But if you're having problems getting your tests on a timely basis, and if you have supplies, I would use the rapid tests for screening as well. Your weekly staff screening can be done that way. But do look at our guidance that we just put out that I just showed you a minute ago, and the link is there. I think it works to clarify an awful lot about the antigen tests.
All right. Here is another unanswered question. Where do the IL communities with HFA waivers fall as it relates to the executive orders?
Right. I didn't list that as an ongoing question because we've asked it so often and have never gotten any clarification about that. But we can continue to list it. I do wish that we had a little bit more guidance from the governor's office about what the intention is there. And we will continue to work on that.
Okay. Does the reporting of a contractor also apply to the definition of facility staff and who to include in weekly testing? So do we need to have our lab, vending machine, stock individuals, etc. do weekly testing?
If a person, a specific individual comes into your facility on a routine basis, they have to be tested weekly. Now, they could be tested by some other entity because they are going to several facilities and they might be tested by their own originating agency as well. They have to be tested by someone. If indeed they're not being tested by you, you need to document their test results on a weekly basis. If they're not being tested elsewhere, you need to make sure that they're being tested. And you need to report any positive findings for that person as if they were your staff.
Okay. For the new AL antigen machines, will we need a CLIA waiver?
That's one of our questions that's outstanding, and we don't have any more information about that. Because it's kind of a different test, we're not sure. The thing about it, though, is that there is specimen collection that is similar, just like other testing regimens as well. So, and there are some requirements for that specimen collection. You have to be careful. So we're not sure. A CLIA waiver might be required, and that might be a problem. However, you know, the FDA may waive all that. We don't have information about that at the time. We have considered that issue as well.
All right, sounds good. As of right now, I don't have any questions, but in case anybody is typing anything, at this point, we would like to thank Deanna, Dalton, and Dave for joining us today. And we would also like to thank all members and participants. I believe we had around 70 people join us today that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Like I said, if you do have any questions or anything that pops up in your head, maybe after you leave here, we do have the emails listed up on the screen right now, so you can shoot an email off to any of those, and we will make sure that we get an answer for you. And just to clarify as well as what Deanna said, we have our Leadership Institute next Wednesday and Thursday, so we will not be holding a Safe and Calm webinar next Wednesday, and we will reconvene next Friday, September 11th at 11 a.m. Eastern Standard Time. Other than that, I hope everyone has a great holiday weekend and a great rest of your day. Deanna or Dalton, do you have anything else you'd like to add?
Just everyone stay safe.
All right. Thank you. Have a great day, everyone.
Have a good weekend.